and is going to talk to us about really ready for discharge, preventing readmissions. Just one other comment I'd like to make before Dr. Keller starts her talk is Dr. Keller's already been tweeting about the session today, so if any of you are into tweeting, please do that because it gets the message out as well. Thank you so much.
Hi, good morning, thank you. I have no relevant disclosures. So the goal for our session today is to understand the current state of unplanned readmissions within 30 days after surgery, to assess the factors that might predispose patients to readmission, and to introduce methods we can use to proactively reduce them. So in the United States, we're in a healthcare spending crisis, and readmissions are a major driver of this. In 2011, there were 3.3 million all-cause readmissions, responsible for over $40 billion in costs, and surgical complications have a major role in this. 5 to 10% of all surgical patients are readmitted after surgery. For colorectal surgery specifically, the rates are up to 25% and accrue over $300 million in costs annually. The data we have is most robust for colorectal, so there's some concentration in that. Despite recognizing the issues, rates have remained stable over time. And these readmissions are costly, accounting for over $7,100 per episode. With this in mind, readmissions have become a quality measure, representing performance, and a focus of CMS to improve outcomes and reduce healthcare costs. The CMS Hospital Readmissions Reduction Program penalizes hospitals for higher than expected readmissions. It currently applies only to patients with certain medical and orthopedic conditions, but it's expanding, and we're all going to be impacted soon. Before enhanced recovery pathways and minimally invasive surgery were commonly used, this was the case. Readmissions were not able to be predicted. And this unpredictable sequelae was suggested to be a poor indicator for quality of care. This is not the case anymore. We all know about enhanced recovery pathways. You're here to learn more about them. They standardize care based on evidence-based guidelines, optimizing patient recovery and costs. They've been proven to reduce length of stay between 1 and 3 days, reduce postoperative complications, and reduce healthcare utilization. But this is all done without increasing readmissions. Enhanced recovery pathways that aid outcomes in every other segment of the patient experience have not impacted readmissions directly. So how do we reduce readmissions? The first step is by identifying the factors that could cause them. Hospital length of stay is a major contributor. A recent study from Rochester using the 2011 ACS-NSQIP colorectal data assessed the relationship between length of stay and 30-day readmissions. They did a Kaplan-Meier analysis that showed a significant direct relationship between length of stay and readmissions. Using less than equal to 3 days as the mean, they saw the odds of readmission were 13% for lengths of stay 4 to 5 days, 32% for 6 to 8 days, and 37% for lengths of stay greater than 8 days. A study we performed in Cleveland looked at readmission rates specifically in the context of an enhanced recovery pathway, using both open and laparoscopic cases from a departmental database. And we had some similar findings, that the rates of length of stay and readmissions increased directly, with dramatic increases after our mean of 3 days. In the study, we saw that early discharge was possible without increasing readmissions, but it brought up a more important concept, that our patients really are going to select themselves out for discharge and readmission, and we need to pay attention to the patient and disease factors that lead to that. So there is some conflicting data on how to use these factors. Dr. Delaney and his group at Cleveland Clinic looked at 1,180 patients over a year period, finding a 12.7% readmission rate in a mostly open set. A multivariate analysis of these patients found that the risk factors for readmission in this group were primarily disease-related, comorbidities that they're not in control of. And from their results, to reduce readmissions, the best recommendation they had was to optimize these patient parameters, since the disease-related factors really couldn't have a huge impact. Data out of Johns Hopkins looking at the risk factors in a commercial database for patients who underwent colorectal surgery over a 7-year period identified some additional factors. Again, length of stay was seen, as well as the impact of comorbidity, but also stoma cases and proctectomy cases, the postoperative complication of superficial site infections, and discharge to a nursing home. The overall rate in this population of both open and laparoscopic cases was 23%. Looking at just laparoscopic cases over a 5-year period, Delaney and his group found that in this segment there was a 10% readmission rate. But the results were opposite what we're seeing with open surgery, with only disease-related factors having an impact on readmission here. Inflammatory bowel disease diagnosis and pulmonary disease having an increased independent risk. And adding the impact of an enhanced recovery pathway to laparoscopic surgery, Francis et al. Reviewed readmissions over a 7-year period, again finding about a 12% readmission rate. On univariate analysis, this group found that patient, complication, and enhanced recovery factors had a role. However, on their multivariate analysis, they saw that the only independent factors of readmission were compliance with their enhanced recovery pathway and neoadjuvant treatment for rectal cancer. All of the patient and operative factors that were identified with open and laparoscopic surgery without an enhanced recovery pathway did not have an impact on readmissions in this study. The role of postoperative complications can't be left unmentioned. A recent study of general, vascular, and orthopedic patients from the 2011 ACS-NSQIP files found that the most important predictor of readmissions was postoperative complications. And most postoperative complications were complications that occurred after the inpatient stay. In this study, their risk of readmissions increased directly with ASA score, with very high, high, and moderate risk patients having a 10, 7, and 4-fold higher risk of readmission than low-risk patients. They also used the risk calculator, which we can use prospectively so that these patients can be identified. Merck et al. Reinforced the concept of complications on readmission using the 2012 NSQIP dataset for all general surgery cases, finding SSI was the main culprit, and emphasized that most readmissions were for new post-discharge complications that occurred after discharge. Corwell et al. Had consistent findings, looking at elective colorectal resections from the multi-center, statewide Michigan collaborative, finding on multivariate analysis that postoperative complications were the only independent risk factor for readmission. And just a word of caution when you're using the large databases with the impending CMS penalties for readmission. The administrating billing data used by this tool does not reliably describe the reason for readmission in almost a third of cases. So implementation of this measure can result in unwarranted financial penalties. So it's important for us to audit our own outcomes and review our own readmissions. So just a summary of that data, if patients are really ready for readmission. Remember, there's inherent differences in the risk by approach and with using an enhanced recovery pathway, but consistency, length of stay, postoperative complications, and discharge anywhere other than home are going to increase risk. So with this in mind, let's look at some proven ways to actually reduce your readmissions. During the preoperative period, risk assessment and a detailed interview of patient risk factors is important. It's not just age, frailty, and preoperative conditioning are an easy way to gauge patients. And this modified frailty index that was introduced is really an easy eyeball test that we can all use at the intake exam. It's been validated to show correlation with length of stay and reducing readmissions, especially for patients that have a higher grade needing preoperative social work, discharge planning, and closer follow-up after discharge. We can also use risk calculators to help stratify the patients preoperatively. The ACS Risks Calculator is one, but the Maine Health Exchange introduced this calculator that proactively updates with daily events. In their study validating the tool, there was high correlation with low, intermediate, and high-risk patients. So this is something promising that we can implement. During the perioperative period, the most important measure is adherence to an enhanced recovery pathway. There's grade A evidence out of the European ERAS groups that shows that this will independently result in fewer readmissions. We can also develop specific care pathways for high-risk patients. For example, ileostomy creation is the number 2 procedure readmitted, and colostomy creation the number 13 procedure readmitted. So these are prime targets. Deb Nagel and her group at BID introduced an ileostomy pathway that was primarily aimed at patients, nurses, and nursing homes, as well as home nurses, finding that 7 months after initiation, it reduced all readmissions by 14% and reduced readmissions from dehydration from almost 15% to 0. It's an excellent example of when it's okay to change standards in an enhanced recovery pathway to help reduce readmissions. And postoperatively, adding physician extenders for post-discharge calls and identifying patients that need earlier post-op follow-up can help reduce your readmissions. This review of colorectal surgeons from the ACS NSQIP database looked at the timing of complications and the readmissions. It was very insightful. Patients found, looking at the timing over the 30-day continuum after surgery, that most complications happened before patients even had their first postoperative follow-up visit. And looking at the specific complications, the mean time for them to occur was all also before the first postoperative visit, which was a mean of 14 days. So with that timing and specific complications in relation to the follow-up time in mind, you can see that the majority of complications happen before we even see the patients, and a subset of them, if seen earlier, could have readmissions reduced. So to proactively reduce readmissions, we need to understand the underlying cause, as patients in the hospital course are red flags for us. Reducing complications using preoperative risk stratification and improving inpatient care, education, and discharge planning can help. So in conclusion, we just have to keep in mind that patients are really going to select themselves out for discharge and for readmission. And we need to do better evaluation of existing comorbidities that they have and use tools to risk stratify them appropriately. We need to watch closer for acute conditions that are going to develop after surgery and monitor our own outcomes and audit our readmissions to avoid penalties. Thank you.